Hello everyone and welcome to our module on non-Hodgkin lymphoma. By way of review, lymphomas are malignancies of lymphocytes like B cells and T cells, and the malignant lymphocytes form a mass. That's why the word oma is in the name lymphoma. And these masses often occur in the lymph nodes, which is where B cells and T cells reside, but you can also find them in other places in the body where B cells and T cells are found, places like the skin or GI tract. These are sometimes called extranodal lymphomas. Because lymphomas involve malignant cells that form a mass, the key diagnostic test is usually a tissue biopsy, often a biopsy of an enlarged lymph node. That biopsy will show evidence of malignant lymphocytes. If the malignant lymphocyte is a Reed-Sternberg cell, then it is a case of Hodgkin lymphoma. If the malignant lymphocyte is not a Reed-Sternberg cell, then it is a case of non-Hodgkin lymphoma. Before we talk about specific types of non-Hodgkin lymphoma, let me review some of the clinical features of non-Hodgkin lymphoma and how it differs from Hodgkin lymphoma. In another video, I talk about Hodgkin lymphoma, but it's often a localized problem limited to one set of lymph nodes. It often has an orderly spread from one group of lymph nodes to another, and extranodal involvement outside of the lymph nodes is rare. Non-Hodgkin lymphoma, on the other hand, often involves multiple peripheral sites, and it can spread in a non-contiguous manner. In addition, extranodal involvement is common. For example, non-Hodgkin lymphoma can involve the GI tract with thickening of the bowel wall, or the skin, or many other organ systems. You should also be familiar with Waldeyer's ring. This is the lymphoid tissue in the pharynx. Shown on this picture at the bottom right side of the screen are the different lymph node regions of the body. Waldeyer's ring is in the back of the mouth in the pharynx. Enlargement of lymph nodes in this region often occurs in non-Hodgkin lymphoma, but it's very rare in Hodgkin lymphoma. And if you're aware of this, it can help you to distinguish the two clinically. Before we go any further, I want to review this slide from our video on acute leukemias. This slide shows lymphocyte antigens. These are surface markers that are found on lymphocytes, and I've broken them down by those that are primarily associated with T cells versus those that are primarily B cell associated. You probably know from immunology that CD4 and CD8 can be found on certain T cells, but you should also be aware that CD1, 2, and 3 and also CD5 and 7 are found on some T cells. In contrast, the surface antigens found on B cells are usually higher numbers. For example, CD10 is found on developing B cells, and CD19 through 23 can also be found in cells of B cell origin. If you can remember this simple rule of thumb that these lower numbers often go with T cells and the higher numbers go with B cells, it's very helpful in understanding the non-Hodgkin lymphomas. As we will see, some of them derive from T cells and some from B cells, and the surface antigens found on each lymphoma will be different depending on which type of lymphocyte B or T cell became malignant to cause the disorder. So now let's talk about the non-Hodgkin lymphomas. These are all B and T cell malignancies, although most of them are B cell disorders. The B cell disorders are far more common than the T cell disorders. And in these disorders, the malignant cells obliterate the lymph node architecture and change it. We'll talk about that in more detail going forward. There are more than 24 subtypes per the World Health Organization, and this can be very confusing as a medical student, and they are classified in lots of different ways. They're classified by whether they derive from B or T cells, by the cell size, the appearance under the microscope, the expression of the surface markers we talked about, that's called the immunophenotype, and also by the genetics. What I'm going to do in this video is go over the most common types and try to tell you how to recognize them, especially for questions on step 1. If you want to read more, you can learn about all the different subtypes that are out there. There are many, many variants of non-Hodgkin lymphoma. Shown on the slide are all the subtypes of non-Hodgkin lymphoma that we'll talk about in this module. Only these last two involve T cells. Most of these involve B cells, as I told you previously. To understand the naming of many of the subtypes of non-Hodgkin lymphoma, we need to review the normal architecture of the lymph node. I discussed this in more detail in the immunology section. By way of review, the outer portion of a lymph node is called the cortex, and within that portion you can find follicles, which are circular structures that contain B cells. So one of the subtypes of non-Hodgkin lymphoma is called follicular lymphoma, and that's because it involves growth of follicles. The region surrounding the follicle is called the mantle, so there is another non-Hodgkin subtype called mantle cell lymphoma, which involves cells that come from this region. And then finally, outside of the mantle, there is another region called the marginal zone, and so there is a subtype of non-Hodgkin lymphoma called marginal zone lymphoma that involves cells from this region. So if you understand this normal lymph node architecture, it's easier to understand the naming of the non-Hodgkin lymphomas. And here's another picture of lymphoid follicles, the way they appear under the microscope. You can see these circular regions labeled number 3. Those are the follicles. The first type of non-Hodgkin lymphoma we'll discuss is called diffuse large B-cell lymphoma. This is the most common subtype of non-Hodgkin lymphoma. It represents about 25% of all cases of non-Hodgkin lymphoma. Like the name implies, it's a B cell malignancy, so the cells express CD19 and CD20. And remember what I told you before, these higher numbers around 20, like 19, 20, 21, and 22, those are all B cell markers. In addition, most of the cells in this malignancy express surface immunoglobulin just like normal B cells. This is an example of a biopsy specimen of diffuse large B-cell lymphoma. It's very difficult to recognize the cancerous cells if you're not trained in pathology. I don't recommend that you try to do that. What you should be able to appreciate, however, is that the normal lymph node architecture, including the follicles, has been obliterated. This is a cancer of older patients. The median age at presentation is 64 years. And very importantly and high yield, this lymphoma occurs in patients who have HIV when the CD4 count gets very low. It is considered an AIDS-defining illness. You probably think of AIDS-defining illnesses as things like pneumocystis pneumonia or infections that occur when the CD4 count gets very, very low. However, this lymphoma also occurs when the CD4 count gets very, very low, and thus it's considered an AIDS-defining malignancy. And the lymphoma often improves if patients have treatment and their CD4 count climbs. The prognosis is variable depending upon a number of clinical factors. There's something known as the International Prognostic Index, or IPI score, which can be used to estimate a patient's prognosis. I don't recommend you memorize this, but the features of the IPI score should make sense to you. Obviously, the older the patient is or the worse their functional status, the worse their prognosis. In addition, the clinical stage of the tumor and the number of extranodal sites influence the prognosis. The treatment of diffuse large B-cell lymphoma is complex and not something I recommend you try to learn for step one, but one thing you should be aware of is that the antibody rituximab can be used to treat this lymphoma. Rituximab is a monoclonal CD20 antibody, and as I told you before, these tumor cells are positive for CD20, so rituximab is used in CD20 positive B-cell lymphomas. That includes diffuse large B-cell lymphoma and also follicular lymphoma, which we'll talk about next. So that's a nice segue into follicular lymphoma, and follicular lymphoma is easy to recognize under the microscope because what you see is an abundance of follicles as shown on this picture on the screen. This lymphoma is also a B-cell malignancy. The cancer cells usually express CD19 and CD20. They often also express surface immunoglobulin. We talked about many of these features being present in patients with diffuse large B-cell lymphoma as well. However, you shouldn't confuse the two malignancies because, as we saw in the last slide, follicular lymphoma has an abundance of follicles in the biopsy specimen. Diffuse large B-cell lymphoma has obliteration of the normal lymph node architecture by the lymphoma. The genetic hallmark of follicular lymphoma is a translocation between chromosome 14 and chromosome 18. If you look at the bottom of the screen, I've shown a depiction of chromosome 14. It contains the gene for the IgG heavy chain. Now, B cells like to make antibodies, so they often heavily use this IgG heavy chain. On chromosome 18, there's a gene called BCL2. In this translocation, the BCL2 gene gets translocated so that it is right next to the IgG heavy chain. Thus, as B cells do what they normally do and express the IgG heavy chain, they will also overexpress BCL2. This is a problem because BCL2 blocks apoptosis. It's considered an antagonist of apoptosis, and this can lead to uncontrolled growth of B cells. The B cells in germinal centers usually lack BCL2. This is because they frequently undergo apoptosis unless they're selected by the process of somatic hypermutation. I talk about this process in more detail in the immunology modules. What this means is that the B cells in the germinal center are supposed to lack BCL2, and thus they're supposed to die frequently via apoptosis. When BCL2 is overexpressed, they do not die like they're supposed to, and this leads to excessive growth and follicular lymphoma. This is also a cancer of older patients. The median age at diagnosis is 65 years. It has an indolent course. It can wax and wane for years. Not all patients need to be treated, and it's very difficult to cure. And the feared outcome of this lymphoma is that it will convert to a diffuse large B-cell lymphoma. This happens in about 10 to 70% of cases over time, and when this occurs, the prognosis is poor. Now, in follicular lymphoma, there is growth of the follicles in lymph nodes. However, in the setting of infection, there is reactive growth of the follicles in lymph nodes. So it is very important to distinguish follicular lymphoma from reactive lymphadenopathy. Both conditions display follicular growth, and obviously one is a malignancy and the other is a normal reaction to an infection. In reactive lymphadenopathy, recall that there is somatic hypermutation of the B cells. I talk about this in detail in the immunology modules. Basically, B cells are adapting to the infectious agent, and many of the B cells are undergoing apoptosis. The apoptosis leads to buildup of debris, which is cleaned out by macrophages, and thus the presence of macrophages will be seen in reactive lymphadenopathy. This is less commonly seen in follicular lymphoma, where, as we have described, apoptosis is not occurring normally. So on this slide, I've summarized some of the ways you can distinguish follicular lymphoma from reactive lymphadenopathy. First of all, in follicular lymphoma, the follicles have a similar size and shape. In reactive lymphadenopathy, some of them are developing more than others, and thus you will see a varying size and shape of the follicles. In lymphoma, there's a relative absence of macrophages because B cells are not undergoing apoptosis as they should. On the other hand, in a reactive lymphadenopathy, there are what's known as tingible body or debris-laden macrophages present. These macrophages are cleaning up the debris from the B cells that have undergone apoptosis as a result of somatic hypermutation. And then finally, if you perform staining for BCL2, it will be markedly positive in most cases of follicular lymphoma. It will be negative in cases of reactive lymphadenopathy. Moving on, next let's talk about mantle cell lymphoma. This is also a B cell malignancy, and it arises from the mantle around the follicle, which we discussed previously, or sometimes from the germinal center. These are B cells, so the malignant cells usually express CD19 and 20, and most of them express surface immunoglobulin. A unique feature of the cancer cells in mantle cell lymphoma is that they express CD5. CD5 is usually a T cell marker, but it's co-expressed with CD20 in this lymphoma. So co-expression of CD20, a B cell marker, and CD5, a T cell marker, is unusual. Thus, you will often read in textbooks about how this lymphoma has cells that co-express CD20 and CD5. This is also a cancer of older patients. The median age at diagnosis is 68 years, and it has an overall poor prognosis. Most patients only survive a few years after diagnosis. When we talked about follicular lymphoma, we talked about how a translocation between chromosomes 14 and 18 was common, and it turns out that a number of the non-Hodgkin's lymphomas have a particular chromosomal translocation that commonly occurs. In the case of mantle cell lymphoma, more than half of cases have a translocation between chromosome 11 and chromosome 14. If you look at the bottom of the screen, once again we have the Ig heavy chain on chromosome 14. In the case of mantle cell lymphoma, the cyclin D1 gene from chromosome 11 is translocated so that it's next to that very active IgG heavy chain gene inside of B cells. This leads to overexpression of cyclin D1, and the gene product of the cyclin D1 gene promotes cell cycle transition from the G1 to the S phase, and thus cells grow more rapidly, and this leads to unregulated growth, which leads to mantle cell lymphoma. Our next non-Hodgkin lymphoma is called marginal zone lymphoma. These are also B-cell malignancies, and in order to understand these malignancies, you need to always remember that the marginal zone forms and expands in settings of chronic inflammation. Thus, this is the type of inflammation that will occur in settings of chronic inflammation. In addition, this type of lymphoma is often extranodal and found in portions of the body where chronic inflammatory disorders occur. So, for example, in the GI modules, I talked about how patients who have Sjogren's syndrome have lymphocytic infiltration of the salivary glands. That can lead to formation of marginal zone cells and marginal zone lymphoma. In the endocrine modules, I talked about how in Hashimoto's thyroiditis, there were lymphocytes drawn into the thyroid gland. That can lead to formation of a marginal zone lymphoma in the thyroid gland. And then finally, in the GI module, we talked about H. pylori infection. Chronic H. pylori infection of the stomach can lead to formation of a marginal zone lymphoma. In that case, it's called a maltoma. MALT stands for mucosal associated lymphoid tissue. It's a maltoma, but it's a form of marginal zone lymphoma. Small lymphocytic lymphoma is another type of non-Hodgkin lymphoma. The malignant cells in this lymphoma are CD5 positive, just like the cells we talked about for mantle cell. They co-express CD20 and CD5. In contrast to mantle cell, however, the cells in this disorder are usually negative for cyclin D1. It's important for you to understand that small lymphocytic lymphoma can present like a lymphoma with swollen lymph nodes and an absence of white cells in the peripheral blood. However, it can also present with swollen lymph nodes and a very high white blood cell count. When the white blood cell count is elevated, the disorder is called chronic lymphocytic leukemia, or CLL. The malignant cells are the same in both small lymphocytic lymphoma and CLL. The only difference is the degree of lymphocytosis seen clinically, meaning how high the white blood cell gets in a peripheral peripheral white blood cell count. If the peripheral blood has normal or mild lymphocytosis, then we call it small lymphocytic lymphoma. On the other hand, if there are more than 5,000 lymphocytes in the peripheral blood, then we call it CLL. But it's the same disorder caused by the same white cells. And in the module on leukemia, I talk in more detail about CLL. Our final B-cell non-Hodgkin lymphoma that we'll talk about in this module is called Burkitt's lymphoma. This is a B-cell malignancy with cancer cells that express CD19 and CD20 and surface immunoglobulin, just like many of the other B-cell non-Hodgkin lymphomas we've discussed in this module. Burkitt's is a very aggressive lymphoma with rapid proliferation of cancer cells, and it's often rapidly fatal. And it has three distinct features that you need to be aware of, especially for step one. First is the starry sky morphology. I'll show you a picture of that in a minute. Second is the association with Epstein-Barr virus, and finally is the C-Myc translocation. This is a picture of the starry sky appearance of biopsy specimens in Burkitt's lymphoma. Shown in the picture are numerous rapidly dividing Burkitt lymphoma cells. These cells have a very high mitotic index. They are rapidly growing and dividing. Because they are growing so rapidly, they create lots of debris, which is cleaned up by macrophages. When macrophages come in and clean up the debris, they create clearing spaces like the one I'm circling with my pen. This creates an appearance that's described as a starry sky with lots of cancer cells interspersed with white areas which are filled with macrophages cleaning up debris. There are two forms of Burkitt's lymphoma. One is called the endemic form, the other is called the sporadic form. The endemic form occurs in places like Africa and New Guinea, where there's a high prevalence of Epstein-Barr virus infection. This leads to the endemic form of this lymphoma. And in some parts of Africa and New Guinea, this represents up to half of childhood cancers because there's such a high prevalence of Epstein-Barr virus infection. It typically occurs in children 4 to 7 years old, and it more commonly occurs in boys with a male to female ratio of 2 to 1. And very high yield for you to know this fact, that the endemic form of Burkitt's lymphoma commonly presents as a mass in the mandible. The mass in the mandible is a classic presentation of this form of Burkitt's lymphoma. The sporadic form, on the other hand, occurs outside of Africa and New Guinea. It can occur anywhere. It also occurs in children. And in contrast to the endemic form, this form of Burkitt's lymphoma presents as an abdominal mass, usually in the ileocecum or in the peritoneum. And this is a picture of a child from one of the endemic regions where Burkitt's lymphoma occurs. You can see that he has a mass in his mandible, and if you see a picture like this on the USMLE Step 1 exam, you should think of Burkitt's lymphoma. As I've alluded to already, Burkitt's lymphoma is associated with Epstein-Barr virus infection. The Epstein-Barr virus is a herpes virus that infects B cells, so it should make sense to you that it can lead to a B cell malignancy. And nearly all endemic tumors of Burkitt's lymphoma, those that occur in Africa and New Guinea, are associated with latent infection with the Epstein-Barr virus. The sporadic tumors are much less frequently associated with Epstein-Barr virus. And very importantly, the Epstein-Barr virus uses the CD21 surface marker on B cells to gain entry to the cells. So if you know that, then it should make sense to you that all the endemic tumors associated with Epstein-Barr virus infection will have tumor cells that express CD21. Burkitt's lymphoma is also associated with a chromosomal translocation called a C-Myc translocation. C-Myc is a gene that's found on chromosome 8. It is a growth promoter and it activates transcription. It's often translocated to chromosome 14 next to the IgG heavy chain, and just like we've talked about a number of times in this module, this leads to overexpression of the C-Myc gene by B cells, and that leads to excessive growth. I'll finish this module by discussing two T-cell malignancies. T-cell malignancies are much less common than B-cell disorders. The first one we'll talk about is T-cell leukemia lymphoma. This is a CD4 positive T-cell malignancy, and it occurs in the setting of infection with the HTLV1 virus. This is an RNA virus that infects CD4 positive T-cells, and patients who have this white blood cell malignancy will have anti-HTLV1 antibodies present. This disorder occurs in parts of the globe where the HTLV1 virus is found. So the clinical scenario to know about for your boards is a patient from Japan, the Caribbean, or West Africa. These are the endemic regions for the HTLV1 virus. Patients will present with a lymphocytosis. That's why the word leukemia is in the name of the disorder. They will also present with lymphadenopathy. That's why the word lymphoma is in the name of the disorder. And then a high-yield rule of thumb to be aware of is the fact that most T-cell malignancies involve the skin in some manner, and that's true for this one as well. So these patients can present with skin lesions. They may develop ulcers, nodules, or a papular rash. The symptoms are rapidly progressive, and this is a serious disorder. It's usually fatal within a few months. Another feature of T-cell leukemia lymphoma to be aware of is that it can result in lytic bone lesions with hypercalcemia. Now, lytic bone lesions and hypercalcemia are a hallmark of multiple myeloma, and you don't want to confuse this disorder with multiple myeloma. Patients with multiple myeloma do not have lymphadenopathy and skin lesions. They usually do not have lymphocytosis, and they usually aren't from one of these characteristic regions of the globe. Our final lymphoma is called cutaneous T-cell lymphoma. As the name implies, it's a skin disorder of malignant T cells. These T cells display variable expression of CD markers. There are lots of different markers that can be seen, and there isn't a classic collection of markers that you should know for this disorder. It presents with skin lesions, and there's a spectrum. It can be a localized condition, which is called mycosis fungoides, or it can be a diffuse systemic disease called the Sézary syndrome. Mycosis fungoides is the localized version, and the name is a misnomer. This has nothing to do with a fungal infection. It presents as patches, plaques, and tumors of varying size and shape. The lesions progress slowly over time, changing size, shape, and appearance. And one of the things you worry about when a patient has a rash that won't go away is that it could be a malignancy, and that's one of the many reasons that skin rashes that don't resolve are often biopsied. It's an indolent lymphoma, so it's slowly developing over time, and the classic distribution, although there's a lot of variability, is for it to occur in what's known as a bathing trunk distribution, meaning on the lower abdomen and upper thighs. The diagnosis is made by skin biopsy, and it will show lymphoid cells, and this is the key feature you should know about for step 1. You'll see lymphoid cells in the upper dermis. They can also form aggregates in the epidermis, which are called Poitiers microabscesses. The Sézary syndrome occurs when the T-cell lymphoma affects the skin of the entire body. There will be widespread erythema. The skin will be bright red all over. There will also be lymphadenopathy, and characteristically, the malignant cells enter the bloodstream. These are called Sézary cells. They look like the picture I've shown on the screen. Their nucleus is described as being cerebriform, meaning it looks like the brain because it's multi-lobed. You can also see cells like this in the skin of patients with cutaneous T-cell lymphomas. And that concludes our module on non-Hodgkin lymphoma.